Hello, this is Sudharshan, and in this episode, we will talk about Chapter 28 Basic Cardiovascular System Infections. We will talk about two important conditions, that is, infective endocarditis and rheumatic heart disease. So, coming to infective endocarditis, as the name itself tells, the inner layer, that is, the endocardium in the heart, is infected, and there is inflammation also. And there are two important kinds of endocarditis, acute and subacute. So acute is faster and opposite. Okay, so I will tell the features of acute, and subacute will be opposite. So acute is much faster, and very importantly, in both acute and subacute, acute is the normal valve and subacute is the pathogenic, that is the diseased valve. And in acute, the number one cause would be Staphylococcus aureus, and with respect to subacute, it would be viridin streptococci. And with respect to the prognosis, it is much challenging in the acute because Staphylococcus aureus has multi-drug resistance and the array of infections is much higher. And subacute is more common compared to the acute. And if we see the pathogenesis, it is divided into three phases. Endothelial injury, four phases: endothelial injury, colonization, vegetations, and metastasis. So endothelial injury, as the name itself tells, the inner lining of the blood vessels is affected. So when the bacteria will enter into the bloodstream, it will affect the inner lining of the blood vessels and it enters the heart. So it will try to infect the cardiac valve, and mainly this will occur as a risk factor where prosthetic devices are inserted into the heart. It will infect even the prosthetic devices. So there it forms an important condition, that is NBTE, or non-bacterial thrombotic endocarditis. As the name itself tells, the inner layer of the heart is infected with clot, and there are other reasons apart from bacteria. And coming to colonization, so once the bacteria have invaded the cardiac valve, they will multiply and they will form a biofilm, that is a protective layer, so that it can evade the host immune response and also not respond to antibiotic therapy. And this can occur from immediate infection, like brushing the teeth, for example. So biofilm is very important here in colonization. And these also can behave like an embolus. That means they can travel as a group along with the biofilm and infect the various other sites in the body. So disseminated infection, to be specific. And vegetations. So as it is damaging the endothelium, even the fibrin and platelets, so a meshwork will be formed. And metastasis, as I already told, like an embolus, it will spread to various sites, disseminated infection. And what are the causative agents? Number one, Staphylococcus aureus, then viridin streptococci, and the HESEC group of organisms. So this is H for Haemophilus parainfluenzae, A for Aggregatibacter species, C for Cardiobacterium, E for Eikenella, and K for Kingella. I repeat, this is very important. HESEC, H for Haemophilus parainfluenzae, A for Aggregatibacter, C for Cardiobacterium, E for Eikenella, and K for Kingella. And coming to clinical features, so we can have cardiac and extracardiac manifestations. So we now will see the extracardiac manifestations. So mainly a flu-like illness like fever, malaise, fatigue, myalgia, arthralgia, and we can also have headaches, sweats, weight loss, hepatosplenomegaly, lymphadenopathy. And apart from that, it can also cause anemia and some other important clinical signs like Osler's nodes, rod spots and Janeway lesions. And coming to the diagnosis, very important, we see Duke's criteria. So we have two important major and minor criteria. In major, we can have two positive blood cultures and endocardial involvement. In this, the inner layer of the heart is involved, and on EKG, we see an intracardiac oscillating mass. That is, it's a mass that moves like a pendulum, and we can visualize it inside the heart. And also there is a dehiscence or the breakdown of the prosthetic valve. This is an important EKG finding. Coming to minor criteria, we can have immunologic phenomena, we can have vascular phenomena, we can have fever, we can have IV drug abuse, and also microbiological evidence. And coming to the different combinations which we can take. Two major criteria, we can also have one major plus three minor, or all five minor criteria. I repeat, two major criteria, one major plus three minor, and five minor criteria. And on labs, anytime there is an infection, ESR, CRP and WBC counts are elevated. And since the joints are infected, we will see for RF, rheumatoid factor and citrullinated peptide or anti-CCP. And apart from that, we can have this automated methods for the analysis. And coming to the treatment, we can have for MRSA, methicillin resistant staph aureus. So we can give other synthetic penicillin preparations like cloxazillin, nafcillin. They can also be combined with gentamicin, rifampicin, with third generation cephalosporins. As a combination therapy, we can give for 6 weeks. Very commonly, they are given IV. So that was with infective endocarditis. Next, coming to rheumatic fever or rheumatic heart disease or acute rheumatic fever. As the name itself tells, there is fever with joint involvement. Rheumatic means joint, and it is an autoimmune disease and very commonly caused by gas, that is group A strep, as a result of throat infection. And there are two important theories to note: autoimmune theory and cytotoxic theory. As the name itself tells, in autoimmune theory, so it is autoimmunity, M protein. So this is important. M protein is there where we see the formation of immune complexes. So somewhat like a hypersensitivity type 3 reaction. It will be deposited in various sites. And cytotoxic theory, as the name itself is telling, harmful to the cells where it produces the toxins like streptolysin O and S. And coming to clinical features, for that we have a mnemonic space. S for subcutaneous nodules, where we find bumps below the skin. Then P for pancreatitis, that is the inflammation across the heart. It can also lead to myocarditis, the number one cause of mortality because of rheumatic heart disease. And A for arthritis, very commonly migratory polyarthritis. As the name itself tells, different joints are inflamed, and if one joint is inflamed, it will affect rest every joint. Just like what rheumatoid arthritis is, from small to large joints can be affected. Then we can have chorea, which is nothing but a jerky lesion, and E for erythema marginatum, which are nothing but the red rashes, which are initially in the trunk and then spread to various parts of the body. And very important in erythema marginatum, they will appear and disappear. And all these conditions are diagnosed by very important criteria, Jones criteria. So very commonly we can have two major, or we can have one major and two minor criteria, or sometimes even three minor criteria also we can take. And coming to the treatment, we can have penicillin G as the drug of choice. And on labs we can see ESR and CRP as elevated. So that was all with the basic cardiovascular system infections. So thank you so much. I'll see you in the next lesson.